Sulfonylureas. These are oral anti-diabetic drugs that are used in treating type 2 diabetes mellitus. They are called insulin secretagogues because they stimulate insulin secretion from pancreatic beta cells. They are divided into first generation and second generation. Tolbutamide and chlorpropamide are first generation drugs, while glibenclamide, glimepiride, glipizide, gliclazide are second generation drugs. These second generation drugs are more potent than the first generation drugs. The mechanism of action of all these drugs is same. However, they differ in potency and duration of action. To understand the mechanism of action of sulfonylureas, let us first look at the pancreas. The pancreas contains clusters of cells called the islets of Langerhans. It includes two types of cells, the alpha cells and the beta cells. Alpha cells secrete glucagon while the beta cells secrete insulin. The entire mechanism of action revolves around these cells. Sulfonylureas bind to the receptor on B cells. This blocks the ATP-sensitive potassium channel. Potassium cannot leave the cell and positive charge starts accumulating inside the cell. The cell becomes less negative. This is called depolarization. Depolarization opens voltage-gated calcium channels. Calcium rushes inside and it causes insulin granules to fuse with the cell membrane. Stored insulin is then released into the blood. Hence, sulfonylureas stimulate insulin release. They do not produce insulin. They also increase sensitivity of peripheral tissues to insulin by increasing the number of insulin receptors. Uses. The major indication is type 2 diabetes mellitus. Sulfonylureas are effective only if sufficient functioning pancreatic beta cells are present to release insulin. They can be used alone or combined with other drugs like metformin. However, they are ineffective in type 1 diabetes mellitus because type 1 diabetes mellitus is caused by autoimmune destruction of pancreatic cells. So, if there are no beta cells, insulin stores are absent, which means sulfonylureas have nothing to release. The adverse effects include hypoglycemia, which is especially common with glibenclamide because of its long duration of action. That is why it is generally avoided in elderly patients. Other effects include nausea, vomiting, diarrhea, flatulence, weight gain, etc. Some patients may also experience skin rashes, itching, or photosensitivity. Chlorpropamide can produce a disulfiram-like reaction with alcohol by inhibiting aldehyde dehydrogenase, leading to acetaldehyde accumulation. So, alcohol intake can produce flushing, vomiting, headache, and discomfort. Moving to drug interactions, salicylates, sulfonamides, propranolol, and warfarin increase the risk of hypoglycemia with sulfonylureas, whereas rifampicin and phenobarbital increases their metabolism, thereby reducing their hypoglycemic effect. Sulfonylureas are not safe during pregnancy. And that wraps up a high-yield overview of sulfonylureas.